You want to give it a few more minutes, or would you like to get started, Dr. O'Keefe?
7:30. I think it's fine to just, start, get started, and then there'll be more people joining, but hold on one second. It seemed like last time there was a whole bunch that came on just like, the first 5 minutes.
Yeah, no, I think we could wait a few minutes. That's fine. It may be. All right, everybody. We'll go ahead and get started as a few more people trickle in. Welcome to session 2 of Learning to Code ECGs with Dr. O'Keefe. My name is Evgeny Karatin. I'm one of the third-year cardiovascular disease fellows at Mid-America Heart Institute. Our first session this past Saturday went very well. We had a lot of active participation, and we would certainly encourage that today. Please feel free to whenever there's an opportunity to read an EKG, to chime in and try and read the whole ECG. And alternatively, you can also place your name in the chat box, and we'll be able to call on you that way. But again, just participation is strongly encouraged, just because it's a unique opportunity to learn how to do this with Dr. O'Keefe, who's been generous and dedicated his time to teach us how to ace these aspects of the board examination. In terms of etiquette for the presentation, just a few quick reminders. If you can silence your microphones just so that there's no additional noise. If you have any additional questions or questions on any particular ECGs, please direct them towards our chat box, and we'll try and go ahead and answer them with the individual ECGs. And if for any reason we can't get to them, we'll try and answer those questions at the end of the presentation. And then finally, again, participation is strongly encouraged. As far as the recording goes, we had just a little bit of an issue with the audio recording the last time, but we should have that rectified. So this will be recorded and then posted on a dedicated YouTube channel that we are in the process of developing, so that you can go back and review the ECGs as well as the coding strategies. Well, without further ado, I'll go ahead and have Dr. O'Keefe share his slides, and we'll get started.
Okay, Yev, can you hear me all right?
Yes, we can.
Okay, good. We'll go ahead and get started. So, yeah, thanks everybody for joining us this evening. I know you probably had a busy day, but this will be fun and interactive. This screen that you're seeing, can you see the screen right now? The OKeefe ECG screen. This is the website that I created over the last 3 years or so, and we've sort of curated 133 and adding more all the time. ECGs that are especially relevant for the boards. They have diagnoses that are commonly tested on the boards. So, so we think, and it's set up in an interactive way. You'll see we'll be using it while we present these cases, but it's a highly effective way to really get yourself in a position to excel on the ECG section of the boards, which has traditionally been an overrepresented part of the cardiology boards. So anyway, well, we'll go ahead and get started and ask for volunteers for each of the case and each of the cases. We'll kind of skip around here, but let's see. We'll start with an easy one here for somebody who wants to volunteer. So
Perhaps Ate can take the first one.
okay. So this is a 75-year-old male with ischemic cardiomyopathy who lost consciousness while getting this tracing. So anybody want to take a wild shot at that artifact?
Refab.
What?
Ventricular fibrillation.
Right. Perfect. Yeah. All right. And I know you probably wouldn't be looking at the ECG at this point. You'd be, getting the pads on, getting ready to cardiovert him out of that. But yeah, this is a pretty simple, straightforward case of ventricular fibrillation. So you'd code that. That's one of the codes you have. And, move on to the next one. You get about 3 minutes per unknown ECG in the cardiology board. So, when you see ventricular fibrillation, there's really not much else to really talk about there. So we'll just submit that answer yeah, that's the correct answer, obviously. So let's look at another one here. So this is an 85-year-old male who's been on amiodarone for intermittent atrial fibrillation. So maybe you want to volunteer to take that one? Guess you want to be able to see the rhythm strip down there too.
I think this is first degree block with PAC, I see.
Very good. There's the PAC, yep. Anything else?
I think there's also prolonged QTC.
Right. It's a big long QT. And that kind of goes along with the amiodarone, right? And that's about it. So if you count these out, it's actually sinus bradycardia. So you'd code, and by the way, this score sheet that we're working with, it's on OKeefeECG.com on this website. This is pretty much identical, except for a little bit of verbiage changes, but the same 89 diagnoses that you'll see on the board score sheet. So yeah, this is first degree AV block with a sinus bradycardia, and there's QT prolongation, and an atrial premature contraction. So let's see if there's anything we missed on there. So yeah, we got all that right. With these antiarrhythmic agents like sotalol or dofetilide, dronedarone, amiodarone, these class 3 agents, you often will see things like first degree AV block or bradycardia, prolonged QT. So yeah, you'll probably see, you know, you might see a case of, you know, antiarrhythmic drug on the test. Here's another trickier one here. So this is a 24-year-old male with pleuritic chest pain radiating to the back that improves when he's leaning forward. Now, I just want to emphasize that as in most standardized tests, or for that matter, when you're rounding in the hospital or seeing a patient in the office, the context really matters, you know, the patient you're looking at. So, and they will often give you major clues in the little, you know, clinical vignette, the clinical scenario. So this is a 24-year-old male with pleuritic chest pain that improves when he's leaning forward. So what do we think of this tracing? By the way, he did have, you know, he's in the ER. His troponin was like 3. And he's got this ECG.
Pericarditis.
Yeah, diffuse ST elevation, sinus rhythm. There's ST depression, V1 and 2, but diffuse.
Yeah. So this guy, yeah, does have acute pericarditis, and let's just, and you can see that, you know, with the sort of concave upward, you know, this hollowed out ST segment elevation, and there's some PR depression here, and some of these you can see some PR depression as well. But that is pretty striking, ST segment elevation. This guy did have myopericarditis, you know, so you'd code the sinus rhythm. And you code the acute pericarditis. These clinical disorders here in the middle, really important to know all those really well, because you'll see several of those on your test, on your board test. I would argue that this is such striking, you know, especially, you know, with the elevated troponin, it's probably useful to code STT changes of myocardial injury. You know, that's something that we don't use a lot. You don't necessarily have to use that for acute infarction. In this case, I think it was the, you know, the myopericarditis that really, you know, saw that sort of striking ST segment elevation. So, so yeah, we got all those right, but acute pericarditis, right? So the other place where we'll code ST segment injury is like in the setting of like Prinzmetal's angina, where it's not necessarily an infarct. You'd kind of you'll probably would have a lot of clues that it's not an acute infarct there, or with a left bundle branch block. Lots of times we don't call acute infarction with left bundle branch block. You could call it with right bundle branch block, not with left bundle branch block, but you can call injury when you see ST segment elevation that that meets criteria, usually in the leads. The ST segment elevation is in the leads that have positive voltage, but maybe we'll show you an example of that. All right. Any questions so far?
Would you regularly code for ST elevation suggestion of myocardial injury with pericarditis, or was it just because of the striking elevation?
Yeah, I think it was just because there was such striking elevation and the troponin elevation that we called injury, but normally you wouldn't with acute pericarditis. And you can call it with acute injury with STEMI, and you probably won't get any credit for that, but you won't be marked off because it's obviously not wrong. I mean, it's an injury pattern with an acute infarction. Okay, so this is a 76-year-old female with chronic kidney disease, severe chronic kidney disease, with a history of atrial fibrillation, who's on digoxin, complaining of fatigue and confusion in the ED. You want to take that?
atrial fibrillation with complete heart block with junctional rhythm.
Very good. So pretty good. So do you think you should call it flutter there or fib? Kind of a trick question.
It seems like more coarse to me. I do not see except V1. I do not see it anywhere else.
Yeah.
I would not be wrong if I say it is coarse AFib.
Yeah, no, you're right. And lots of times on the clinic, in the clinical setting, you'll say, oh, AFib flutter or whatever, but you can't say that on the boards. Like a lot of things, you have to really commit yourself and know what you're dealing with and know what the criteria are. And that's one of the nice things about this website that we created. So like if you want to go in and see the definition of atrial fibrillation, you can click on this little information button and it'll take you to a PDF that shows you an example of the atrial fibrillation and a definition. And like we say, if you see some flutter and some fib, you call it fib. You can't call it fib flutter like we do in the on the wards. So I would agree with you, except this is a really slow rhythm. It's like 30 beats a minute or less, and the QRS is over 120 milliseconds. So the combination of the slow rate and the wider QRS, this is a ventricular escape rhythm. But you are right that it's digoxin. I mean, sorry, it's atrial fibrillation. He's on digoxin, and when you have this, complete heart block, basically, we call this digitalis toxicity, and you'd say it's a ventricular escape rhythm down here, ventricular escape rhythm or complexes. And so that is actually an example of AV dissociation too, because the atria, is not getting down to the ventricle at all because of the high-grade AV block induced by atrial fibrillation. So, yeah, there's a fair amount on this, but do you think you'd code like right bundle or left axis or any of that with it?
Taxes, Dr. O'Keefe, and the other thing I would say technically I argue about the ventricular escape rhythm because the QRS does not seem that wide. Again, I might be wrong. I do not know the baseline, but it could be a slow junction.
I mean, it's a good point. Let me just go to the answer here, and I think they measured the QRS for us. Yeah, see the QRS when we measured it out was 150 milliseconds. So, and the heart rate's 30. So yeah, we coded this, but I mean, your arguments are, and it's a bit of a debatable point. But with stage 3 chronic kidney disease had a digoxin level that was quite high, and so the answers are atrial fibrillation, ventricular escape rhythm, AV block, digitalis toxicity, and AV dissociation. So whenever you see complete heart block, you have to code the atrial and the ventricular rhythm. That's important for the boards. In this case, it's atrial fibrillation is the atrial rhythm, and the ventricular rhythm is a ventricular escape. And you wouldn't necessarily call this digitalis toxicity, except for the fact that the patient's on dig with chronic kidney disease. And so, in fact, the patient did have a digitalis level that was in the toxic range. All of these cases in the OKeefe website are actually, real cases.
Before you go on, if you're coding for a third-degree AV block that implies a dissociation, why do you need to code?
It's a good point. You could probably not code for AV dissociation. It's sort of implied. You might get a point for coding it. It wouldn't be wrong to code for it. And there are several things like that, like left axis deviation in the setting of left anterior fascicular block is redundant. You wouldn't get points for it, but you wouldn't get points marked off for it. Oh, and that was a bit of a trick question before too. If it's a ventricular rhythm like VT, ventricular rhythm of any sort, you don't code things like the bundle branch block, or even the axis is not necessary because, you know, the rhythm is originating in the ventricle. So.
Gentle reminder, everyone, if you can just put your questions into the chat box. If you have any, then I can go ahead and relay them to Dr. O'Keefe just to help with the flow during the session. Thank you.
Okay, so here's a 52-year-old male with complaining of atypical chest pain in the outpatient setting. He's been having some chest pain for the last couple months. Comes to see you for a consult, and here's the tracing. Anybody want to take a shot at that?
So this is sinus rhythm. What strikes me is that P wave and QRS and 1 and AVL are inverted. And so the differential would be either inverted, incorrect lead placement versus dextrocardia. But I see normal R wave progression. So I would probably just say this is incorrect lead placement with sinus rhythm.
Atta is our star from Pennsylvania, who's a EP fellow. So yeah, absolutely right. This is limb lead switch, okay, and yeah, it's right axis deviation with an upside down, you know, P wave and QRS and T wave there, and so you look at the progression of the R wave, and just as a point of differentiation, let's show you this one here. So here's another upside down, you know, PQRS wave here in 1 and AVL, and you'd say, well, this could be a limb lead switch as well, except that when you look over here, now we have this reverse R wave progression. Instead of the R waves getting bigger as you go across the pericardium, they're getting smaller. So yeah, this would be what, Tom?
So this would be dextrocardia. Right,
this would be dextrocardia. And so for dextrocardia, you would code right axis deviation. But for this previous one that we saw, you wouldn't code this one. You would not code right axis because this is just an artifact induced by misplacement of the leads. Okay, so dextrocardia is something that you might, you know, you might see on the boards. Let's look at along a similar sort of vein here. This is a 71-year-old woman with hypertension, atypical chest pain. A week ago, comes in with this tracing. Anybody want to take a shot at that?
So I feel like there's some issue with V2 and V3 here again, because there's bigger R wave in V2 and then smaller R wave in V3. That doesn't make any sense to me. So this could also be incorrect lead placement, this time in the precordial leads.
Exactly, right. That's exactly right. So there's left axis deviation, but it's pretty far, leftward of 40, of negative 45. So, you know, that would be consistent with left anterior fascicular block, right? And then there's some, you know, non-specific STT changes there. But so when you'd code this, there is a incorrect electrode placement that you'd use for, in this case, this is precordial lead incorrect electrode placement, and the sinus rhythm. And then there's left anterior fascicular block that you'd choose out of the interventricular conduction abnormalities down here. So like I say, this is just the way the board score sheet will look. I'd also we'd probably code some non-specific STT changes there. That's the two places where you'd use incorrect lead placement. Yeah. Let's see. We'll go to another one here. a different topic. Okay, so let's try. This is a 45-year-old male with a parathyroid adenoma being seen, for routine sort of preoperative clearance before the parathyroid adenoma resection. Do you want to take a shot at that? Again, keep in mind these clinical scenarios are often
Short QT.
Sinus rhythm, short QT.
Yeah, it is a short QT. There's not a code for short QT on the board score sheet. So
hypercalcemia.
Right, hypercalcemia. That's one of the causes of short QT. Anything else that you'd want to code on this one?
Sinus bradycardia.
Right, there's sinus bradycardia. And along those same lines, there's sinus arrhythmia.
Also, concave ST elevation in the lateral leads.
Mm-hmm. Yeah, those would be non-specific. Non-specific. And this is a 45-year-old, as I recall, he was sort of an athlete too. So they might be sort of the normal variant benign early repolarization abnormalities. But yeah, this would be hypercalcemia, which there is hypercalcemia. When you code any of these hyperkalemia, hypocalcemia, hypercalcemia or hypocalcemia, any of those 4 electrolyte abnormalities there, keep in mind you probably also should code for the STT changes of electrolyte disturbance over here. And yeah, the sinus bradycardia and sinus arrhythmia. When you code, like if there's sinus arrhythmia and it's just a sinus rhythm 60 to 100, you don't necessarily need to code both sinus rhythm and sinus arrhythmia, but we generally recommend that if it's sinus bradycardia or sinus tachycardia, if there's sinus arrhythmia, you code the bradycardia or tachycardia as well.
Dr. O'Keefe?
Yeah.
As a general question, are the boards forgiving when it comes to coding non-specific ST or T wave changes, not necessarily with the suggestive of myocardial ischemia end statement, but just non-specific ST T wave changes?
Yeah, that's it's a non-specific. You're never going to get more than a point or so for that, and they probably wouldn't mark off much, maybe -1 for if they don't think that's right. But yeah, that's oh, we did, they did point out here, that there are these sort of benign early repolarization abnormalities, and there's a little, if you look closely here, there's a little notching at the end of the QRS, and you only see that in a few things like hypercalcemia or benign early repolarization abnormalities or what else? Osborne waves, hypothermia, and that's yeah. So there is first degree AV block here, just barely first degree AV block. Okay, let's take a look at so this is a patient I've been taking care of for quite a while. He's a 51-year-old male he's got stable class 2 angina, diabetes, hypertension, and a history of coronary disease. He comes in, his ECG looks like this, so 51-year-old, black male, asymptomatic presently, but has stable exertional angina. Anybody want to take a shot at that?
I think let's get left axis deviation.
Left axis deviation, right?
I can take a shot. Sinus rhythm. There's some Q waves in the inferior leads, so probably inferior infarct, old, undeterminate. There's some R waves in V1, which could potentially be posterior infarct as well, older age indeterminate.
Right.
And then there's some ST2 wave changes in the lateral leads, the anterolateral leads, that could be suggestive of ischemia.
Mm-hmm. Very good. Very good. So yeah, this is a sinus rhythm with an old inferior and old posterior infarct, and really old. This is like 15 years ago. He had this infarct. He gets a striking ECG, but the STT changes were more noticeable this time than before, and so we would call those consistent with ischemia, along with the old inferior infarct and old posterior infarct with a sinus rhythm. The left axis deviation you could code and you wouldn't probably get credit for it. I mean, it's a, I mean, it wouldn't mark you off for it. I'm not sure you'd get credit for it. The left the left axis deviation is due to the infarct. You know, not a like a true axis shift. But so yeah, the answers, correct answers are sinus rhythm, left axis deviation, LVH. I guess I did get 1 point for that. LVH. Oh, we didn't mark the LVH, but this is a good. You know, the two criteria that I think are most helpful for LVH are the Cornell criteria, greater than 28 when you add up the R in AVL and the S in V3, or just looking for an R wave greater than 11 millimeters in AVL, which he meets it there, and his echo did show mild LVH. So he's got the old inferior and posterior infarcts, and STT change is suggestive of ischemia. So very good on that one.
Dr. O'Keefe?
Yeah.
There's a question in regards to coding left axis deviation in the setting of an inferior infarct.
You know, as I mentioned, it's like we decided to give 1 point for that. It's certainly not wrong. It's a minor point on this ECG, and I think it would be a reasonable thing to do, but it's not a major oversight if you decided not to do that. All right, here's a 19-year-old lady I saw earlier this month. She's a 19-year-old asymptomatic female. She had some palpitation. She's previously, she's 13 weeks pregnant, so they sent her over for just a routine cardiology consult in the office. So there's the tracing. Anybody want to volunteer for this one? Pardon me? All right, I'm not hearing anything.
No,
Okay.
Normal ECG, sinus rhythm with normal ECG.
Right. Okay, it's definitely sinus rhythm. It's a pretty normal ECG. These inverted T waves that we're seeing in the precordial leads here, V1, V2, V2, V3, with inferiorly. This is an example.
Dysplasia.
Yeah, I mean, that would be not an unreasonable guess, but this is actually just an example of juvenile T waves. So it's really a borderline normal or normal variant. It's a sinus rhythm, as I mentioned, but this is a typical example of juvenile T waves. Here, in fact, we can just click on this, the OKeefe ECG website. You just click on the I button, and it shows you another example. This is a more striking example of juvenile T waves, often seen in young females, often in teenagers. Rarely seen in adults, especially adult males. But in this setting, it's a normal variant looking thing. So yeah, there's a few of these, examples on the board that you just need to sort of get that, a lot of ECG reading, like a lot of imaging in cardiology is about pattern recognition, and you just need to see these, which I think why you will find this a very helpful teaching tool. This OKeefe ECG website, if you want to ace the ECG section of the cardiology boards. I mean, I started doing this 35 years ago when I was in your stages, studying for my cardiology boards, and so I put together this consensus criteria definition for all the 89 diagnoses, which have changed a little bit through the years, but it's still sort of a real simple way to really master this material. And All right, so let's do another.
Dr. O'Keefe?
Yeah.
One question about whether if T waves are inverted in only V1 and V2 in an adult, should we code juvenile T wave?
Probably not. You know, they're not going to try to trip you up and get you to call juvenile T waves, 70-year-old male. I mean, it's called juvenile T waves because it's often these sort of confusing T wave inversions with otherwise no other findings in a young person, generally a young female. So I wouldn't worry about it. They're not gonna try to trick you. I mean, they'll send you some standard kind of stuff, but some sort of, like, they might be a little difficult, but if you read the clinical scenario closely, you usually in the ballpark. All right, let's try this one. This is a 74-year-old female with obstructive sleep apnea being seen in the office for fatigue. 74-year-old sleep apnea seen for fatigue.
Junctional rhythm, low voltage, normal axis.
So we felt this was a junctional escape with with sinus arrest, because we didn't really see anything that convinced us that there were P waves. You're right that this is low voltage, less than 10 millimeters in the precordial leads is low voltage. It's 6 millimeters over here, so it's not quite low voltage in the limb leads, but it is in the precordial leads. And then and when you see a rhythm this slow, again, this is like
hypothyroid.
Pardon me?
It's we call it like sinus arrest. Is there a code for it?
Yeah, there's a code for it. Here, I'll show you down here on the there's a sinus pause or arrest. A sinus pause is for the board purposes is greater than 2 seconds. Sinus arrest is when you see a heart rate slower than 40 beats a minute with no like a junctional escape or a ventricular escape with no sinus activity. You could call that arrest, or a big long pause, like more than 4 or 6 seconds. You could also call that a sinus arrest. And then you'd call this AV junctional escape complexes, and the low voltage up here in the precordial leads. And then, yeah, so that should be about it. And the way the scoring goes in the boards is you'll get the most points for the major kind of diagnoses here. In this case, the sinus arrest and AV junctional complexes and the low voltage. So yeah, that's sleep apnea can do things like cause sinus arrest or atrial fibrillation or VT for that matter. So yeah, let's see. Let's pull up another one here. Okay, so this is a 25-year-old male who collapsed out in the field playing soccer. Comes into the ER sort of awake, but complaining of, lightheadedness. Blood pressure is like 90/50. Other true story.
This is ventricular tachycardia.
Right. Well, what about it makes you think it's ventricular tachycardia, just for the, it's the kind of for teaching purposes?
Regular white complex.
It's concordant in precordial leads. It's positive in AVR.
Right. You see this R wave in AVR, ventricular concordance, fast is like 250 beats a minute. And even though it's a 25-year-old soccer player, I mean, this is, and see this bizarre fractionated, QRS, that's another sign that makes you think of VT. In fact, this person did have ARVD, but you don't see any fusion complexes or, because it's so fast, you don't see any evidence of an underlying sinus rhythm, so you don't have to code AV dissociation, but you would code ventricular tachycardia, and that's about it on that one.
Dr. O'Keefe?
Yeah.
Question from the last ECG, and that is, do you always call sinus arrest when there is a junctional escape rhythm?
Well, it depends. A junctional escape rhythm is usually 40 to 60 beats per minute, and accelerated junctional rhythm is about 60. So, but I would say if the rhythm is 55 or something, I wouldn't call it sinus arrest. But if it's below 40 and you don't see any sinus, or maybe 45, I would call sinus arrest.
There was also a question about, just for the sake of applying this in terms of EP localization, where would we suggest would be the origin of the VT based on the CCG?
Oh, gee, I didn't. Yeah.
Perhaps Ate can take this one.
What did you think of that?
Can you pull up the EKG?
Yeah, let me pull it.
His left bundle. This is coming from the right.
Yeah, so if this is left bundle morphology, which it looks like it is, and then
It's going towards the right, but I mean, he's got those big R waves in V1, so I'm not sure it's a left bundle morphology, and it's a bizarre morphology.
Yeah, but since the patient has ARVD, he's probably coming from the right side.
Yeah, that's true, right? Good point. All right, so here's a 44-year-old female with increasing dyspnea on exertion and reduced stamina. Anybody want to take a crack at that one? "44-year-old woman, increasing shortness of breath with exertion and reduced stamina."
I can take it. So it's a normal sinus rhythm. Right ventricular. This is right ventricular hypertrophy with strain and right atrial enlargement.
Mm-hmm.
And right axis.
Good job, Krishna. So this is RVH with strain. There's no such thing as strain on the ECG boards. So, but you got all the essence of it. It's right atrial abnormality, which you often see with RVH, of course. There's right ventricular hypertrophy. There is right axis deviation, and there's STT changes suggestive of hypertrophy, like LVH restraint or RVH restraint. The RVH is typically manifest as these precordial STT, like ST segment depression. This is pretty classic for it. So there's one thing you didn't get that goes along pretty commonly with RVH or LVH, but especially RVH. These are prominent U waves out here in the lateral precordial leads. And there is a code for that, prominent U waves. And of course, you got to call the sinus rhythm, and right ventricular hypertrophy called that, I guess. So let's see if we missed anything on that. You'll probably see an RVH. Yeah, we got all those right. So
is there a code for U waves?
There is a code for U waves. Here, let me pull you for the previous score sheet here. So under repolarization abnormalities, you see, all these various kinds, prolonged QT interval and prominent U waves. And lots of times those two are difficult to sort out. I mean, if you measured this, this might be a long QT, but you don't call it that because that's a U wave out there, not a prolonged T wave. And we tell the difference between a complex T wave and a U wave is because if the U wave starts at an isoelectric baseline rather than say just you have a sort of a hump at the end of the T wave, that would be prolonged QT. But this really starts from an isoelectric baseline, and so that's a distinct U wave.
Dr. O'Keefe?
Yeah.
Question in regards to whether you should code incomplete right bundle.
You know, I was measuring that earlier today, and that is a I think this QT is actually, I mean, this QRS duration is just in the 80 around 85 milliseconds or so. And for incomplete right bundle branch block, let's just pull that up. But I'm pretty sure, I know that of course it's less than 120 milliseconds, but incomplete right bundle branch block. I think that it has to be 90 milliseconds. Yeah, see, it has to be 90 milliseconds in duration, 90 to less than 120 milliseconds. And this did not quite meet. It looked like it, but that's just because there's RVH there. So you wouldn't code it there, but oftentimes you do code incomplete right bundle branch with like acute cor pulmonale or, you know, RVH. So it's a great question, and it's sort of a subtle detail. Since this didn't meet 90 milliseconds, we wouldn't call it. And you can just, you know, if you want to be random on this OKeefe ECG website, you can just take a test and you'll pull up some, you know, just a random one. Anybody want to take this? This is a 71-year-old male with left shoulder aching and dyspnea for 2 days. So left shoulder aching and dyspnea for a couple days.
So I can take a shot at this one. It seems kind of hard.
Yeah.
So, for rhythm, I'm kind of torn between atrial tachycardia versus atrial flutter. I don't see any obvious flutter waves, so I would probably go with atrial tachycardia. And then there is possibly a right bundle branch block, as well as there's S wave in lead 1, Q waves in lead 2, 3 AVF. So maybe left posterior fascicular block as well.
Right. Yeah,
so
posterior fascicular block, right bundle branch block. And this is actually, I believe it's atrial flutter. We can look on the answers, but what do you make of these Q waves inferiorly, Atta?
So this patient may also have old inferior wall infarct.
Yeah, this person does have. Down here, you know, in 2, you can see it more. I think this is flutter with variable block. But yeah, you're right on the conduction abnormalities. That's a complete right bundle branch block. I think that's left posterior fascicular block. And then, you know, with left posterior fascicular block, lots of times you get little Q waves in leads 3 and AVF, you know, just like you get little Q waves with left anterior fascicular block and 1 in AVL. But these Q waves are more than 30 milliseconds, so they're pathologic. It's important to understand what a significant Q wave is, and so greater than 30 milliseconds, which, you know, lots of times you need to just blow it up to look at that, and that's more than 3/4 of a small box. So yeah, so that's an old inferior infarct there. So and do we put in the atrial flutter there? With the fascicular blocks, like left anterior fascicular block, you could call left bundle branch block. Yeah, we got all those right. So that is flutter. Granted, it's not a typical flutter, but those are flutter waves with a variable block and an old inferior infarct. See, this said you could call right axis deviation. You know, with the left posterior fascicular block, but it's redundant, so you wouldn't get extra points for it, just like you wouldn't create extra points for left axis deviation when you call left anterior fascicular block. All right.
Is there any coding for, like, you know, the variable block, or do you just leave that be?
So good question. If you look on the scoring sheet, there's 2-to-1 AV block, which sometimes you'll use with atrial flutter. right? Or of course you can use it with sinus rhythm, or but keep in mind there's a 2-to-1 AV block, but there's not a variable block, so you would just call atrial flutter here. We did this one last time, so we'll skip that one. Okay, here we have a 72-year-old female with chest discomfort and shortness of breath for an hour. Comes in with this startling looking ECG.
She has ventricular bigeminy and also anterior lateral ST elevations.
Right. So where is the infarct? Where would you call this infarct?
Say anterior.
There's V1 to V3. That's anterior or anteroseptal. They lump those two together on the boards. V1, V2, V3 is anterior. Anteroseptal. V2, V3, V4 is sort of anterior. But they lump those two together. So that's anterior, anteroseptal. There's V1 to V4. When you see it over in V5, V6, there's more than 1 millimeter of ST segment elevation there too. So that's anterolateral as well. And then you'll also see it up here in 1 in AVL. So that's an acute lateral infarct. And as you mentioned, there's, it's bigeminy, so you're going to be calling the ventricular ectopy. So what do you make of this ST segment depression down here? Do you call that like ischemia at a distance or reciprocal changes, or how do you score that for the boards?
I think that's inferior reciprocal changes.
Yeah. Yeah, and you could call that clinically, but there's no such thing on the board score sheet. So when you see an acute infarction like this, you can call STT changes of injury. All right, probably might get a point for that, but maybe not. But you would get docked if you pointed if you scored STT changes of ischemia. But this is an acute anterior or anterolateral. It's an acute anterolateral and acute anterior anteroseptal and an acute lateral. Lateral is 1 in AVL for board purposes, acute or recent. There's a sinus rhythm, and it's 96 beats per minute, and so it's sinus, not sinus tachycardia. And you see all these ventricular ectopic complexes, you just call them, there's no bigeminy code, you just call ventricular premature contractions. And I think that's about it. Is there LVH there? Oh, there is LVH. Look in AVL. That's way more than 11 millimeters. So yeah, that's definitely LVH. So let's see if we got that right. You'll probably see several infarcts, and it's really important to understand the sort of the technical aspects. Oh, so there's left atrial abnormality that we didn't call, and left anterior vesicular block here as well. I mean, this is just a whole sort of variety of different diagnoses. Yeah, left atrial abnormality because it's more than 1 by 1 negative in V1 there. So, any questions on that one before we move on? The pretty complicated one, although not particularly hard. It's just you have to pay close attention to the various things on it. Okay, here's a 71-year-old male with a history of mitral valve replacement and heart failure. Pretty straightforward, right?
Yeah. So the underlying rhythm is Afib.
Right.
And there's ventricular pacing. What really strikes me out is that V1 has a positive QRS complex. So this cannot be RV pacing, because if this was RV pacing, you would see left bundle morphology. So this patient is probably being paced from the coronary sinus. So I would say AFib underlying rhythm, and then I would say CRT pacing.
Perfect. Atta is such a star. Okay, so yeah, there's underlying AFib, and when you see, this is classic, when you see a Q wave in one, and you see this positive R wave in V1, that means it's coming, posterior to anterior. Typically for the RV apical pacing, you see the opposite, sort of a left bundle, anterior to posterior, big spike. So yeah, this is CRT pacing, and this is where it's important to understand the board score sheet, because in fact, you have an option for biventricular cardiac resynchronization therapy, biventricular pacing, and the underlying rhythm is atrial fibrillation. So yeah, that's a typical example of CRT LV coronary sinus pacing. All right, almost done. So so this is a 56-year-old female who's had 4 hours of severe chest pain, she actually, she's been in the hospital. Her mother had a stroke. It's another true case. Took care of last year. Mother had a stroke. This lady's been at her mother's bedside for the last 48 hours, no sleep, just emotionally distraught, and comes into the emergency room with a troponin, with chest pain that's been going on for 4 hours. As she's sitting by her mother's bed, she decided to take herself down to the ED, and her troponin is 1.1, and she's got this ECG.
Can I take it?
Yeah. Takotsubo, right.
Yeah.
So she did have the typical Takotsubo findings, and ended up in the cath lab. Before I saw her, they sent her in the cath lab, and then I saw her after that. But because I don't think I've sent her to the cath lab, it's such a classic Takotsubo stress cardiomyopathy, finding. But so we don't have that option on the boards, that Takotsubo stress cardiomyopathy. So you'd call this a sinus rhythm, right? And what would you call all that STT changes stuff?
Myocardial ischemia.
Yeah, you'd call that myocardial ischemia.
And also she has a AV block, first degree AV block.
Right. Good job, Noel. So yeah, that's first degree AV block, and it's you'd call ischemia there, STT changes of ischemia, and I think that QT is probably long. You'd have to measure it out, but as a rough rule of thumb, if it's more than if it's a sinus rhythm, not a tachycardia, and it's more than halfway from the R to R interval, and the QT is longer than half, it's a sort of a quick and dirty way to pick out QT prolongation. So,
Dr. O'Keefe, perhaps we can finish with one last ECG for this evening.
Okay. We'll do maybe we'll just do a random one. See what we'll come up with. We just did a pacemaker one. We'll use another one. Okay, so here's a 59-year-old male with, we might have done that one too. We've done one similar to that, so. Okay, here's a 55-year-old female with non-ischemic cardiomyopathy and COPD. So what do we think here? This is a good one.
So again, sinus rhythm, and then there's right ventricular hypertrophy.
Yep.
Actually, this could be right and left, both you could have right ventricular hypertrophy and as well as left ventricular hypertrophy because lead 3 is more than 20 millimeters positive. So that's consistent with LVH. And
Right.
at the same time, you have evidence of RVH in V1. So this patient may have combined ventricular hypertrophy.
Perfect. Otto, you're such a star. So yeah, there is such a thing you'd call LVH and RVH, and you'd get credit for that. But the right answer, I mean, the truly correct answer is combined ventricular hypertrophy. Not only because, like you say, when you see an R wave greater than 20 millimeters, that's like an R wave greater than 11 over here in AVL. If you see that anywhere in the limb leads, that's LVH. She's also got something called Katz-Wachtel phenomenon, where you get these big overlapping QRSs in the mid-precordial leads, V2, V3 especially. And so that's a sign of combined ventricular hypertrophy. But clearly there's RVH here with this big R wave and the right axis deviation and right atrial enlargement. But there is LVH by several criteria as well. So this is combined ventricular hypertrophy. And what do we make of these STT changes?
You could say secondary to hypertrophy.
Yeah, exactly. That's secondary to hypertrophy. So, right. So that's a wrap for tonight. So thanks a lot for everybody for coming. And do you have anything to add?
Yeah, just one question about the one of the prior ECGs. I think it was the last one. Does the QRS notching help point out CRT as well? What's the question?
Yeah, lots of times that can be something you see, but it's not pathognomonic. I mean, the CRT, well, how you call the CRT is looking for the R wave in V1 and a Q wave in 1 and sometimes AVL as well, telling you it's moving away from the left side and it's moving from posterior to anterior. And it's only LV coronary sinus pacing that'll do that.
Sounds good. Well, thanks everyone for joining me at a very robust showing today. And thanks to Dr. O'Keefe for volunteering his time to going over the ECGs with us. And then finally, thanks everyone for participating. And we appreciate everyone showing up. We will be communicating with all of you and your program coordinators about future sessions. We are still trying to determine the scheduling for the next session. As soon as we have that time and date, we will let you know. And with that, thank you again, and have a good evening. Stay safe.
Oh, and we probably will post this on YouTube, but I think you have recorded it, so we'll send out an email about how to access that.
Yes, yes. Thanks for reminding me. Yes, Dr. O'Keefe is working on the YouTube channel, and we will have this one recorded as well. We had a little bit of a snafu with the first one where the audio did not quite make it on there, so my apologies for that, but this one should be available as soon as we have that up and running.
Okay, bye everybody.